you to scroll through the slides.
Ah, I see. Okay.
Do you see that?
I do.
Okay.
Yes, thank you.
Okay.
Yeah, that's good. Okay, I think we must be. All right. We're getting.
And if all the presenters who aren't presenting could please mute their phones, that would help.
Okay, perfect. Hey, I think we're going to get through this. I think we're on the right track now. So, thank you. Hopefully everyone's seen the meat and poultry processing slide. It's actually the web page from CDC NIOSH, and I'm sure you're all familiar with this. But I wanted to bring your attention to the Poultry Facility Assessment Toolkit, and that's in the upper right-hand corner up in this section. Now, this is an area that has all the resources and tools that were developed by CDC NIOSH, and this is also the area that's going to be housing the communications plan that is going to go through clearance shortly. All right. The Meat and Poultry Facility Assessment Toolkit. So this was a resource developed for safety and health professionals and state and local health department officials. And we want them to use this to assess facilities. And this is a shorter list. The facility checklist is shorter than the facility assessment tool and reference slides that are out there. So this is a list of all the information that is available for individuals to use. The checklist here, it is not necessarily listed in order of importance, and it lists some of the activities that are maybe more important than others. But keep in mind that this is a holistic approach, and if you have a robust mitigation program for COVID-19, you need to implement all the elements to be effective. I really want to note that this checklist was not intended to be used to determine regulatory compliance. It is simply made to aid establishments and safety and health professionals in aligning their policy with the OSHA CDC co-branded guidance. So the items that the facility assessment checklist looks at is the plan itself, the ability to maintain social distancing, promoting personal hygiene, identifying and excluding ill workers from working, providing education and training communication, and then cleaning, disinfection, sanitation of high-touch surfaces, and also an evaluation of PPE, face coverings as appropriate, and evaluating and maintaining ventilation. The longer toolkit that is out there is the facility assessment tool. Now, there is a product called Infection Control Assessment Response Program, and this is a tool that's been out for a long time, but has been adapted for COVID-19. So this tool is also developed to assisting infection prevention practices and to guide quality improvement activities. I would suggest using this tool first. It's much more detailed, and then as you reevaluate your program, use the first tool that I mentioned. Okay, so the facility assessment toolkit, it has the first section is facility workforce and characteristics. So you need to take a look at some basic information. The number of shifts you have, the start time of shifts, the end time of shifts, and break times, name of departments and facilities, how employees are transported to work, primary languages needed for education and communication, union information, and encourage their participation in walkthroughs, and identifying principal points of contacts for agencies such as state and local health departments, USDA, and OSHA. The second part of this toolkit is focused on policies and procedures, and it walks through steps to review your own facility's COVID workplace safety and health plan, and to make sure that you align it with the CDC OSHA guidance for meat and poultry and processing facilities. There's an evaluation as part of this for engineering controls, cleaning, disinfection, entry screening, training and communication, and then PPE for use in the cleaning and disinfection of PPE, and then source control such as cloth face coverings and disposable face masks. The third portion is guidelines and other resources. Now, hopefully this is a one-stop shop service, and it has all of the web links to relevant agencies that you would interact with, and that includes CDC, NIOSH, OSHA, FDA, EPA, U.S. Animal Health Association, the National Association of State Public Health Veterinarians, to name a few. And then the last section, or the fourth section, is really focused on observation and is focused on times and activities, because you want to look at your entire program. So you want to look at a snapshot of what is happening at the start of the shift, the end of the shift, during screening, meal times, breaks, during production, and during cleaning and disinfection. So it's really important to look on the third shift. I've read some articles where the infection rates of the sanitation shift are very similar to the infection rates of the production shift. And so you don't want to forget any aspect or shift that you have. So during all these time frames, this assessment tool will help you evaluate, is there an adherence to social distancing? Is there an adherence to cleaning and disinfection practices? And is hand hygiene facilities available along with PPE and cloth face covering utilization? Here's a quick list of some of the educational materials that are out there on the CDC NIOSH webpage. It's in multiple languages, I believe 22, and it's available for your use. Same thing here, we have posters. Okay. So this is the product, this is section 2 of the presentation, and this is the COVID communications plan. Now the exact title of this is going to be COVID-19 Communications Plan for Select Non-Healthcare Critical Infrastructure Employers. And it is a great tool, and it was put together by communication experts, and it's broken down into messages and how to best communicate with your employees. This particular slide is what I would call the means and methods slide. This is how do you communicate? So there's an emphasis of not forgetting your normal communication modes through supervisors and managers. One consideration is to establish information channels, such as a dedicated phone hotline employees could call about COVID-19, or an email account specifically for these purposes. You also want to create a program where you have continuous feedback, and you want a work group that's composed of frontline employees to evaluate this to make sure it's effective and communications are happening the way they should. Okay, so this plan, it's changed a little bit since it went through clearance, but it has a whole variety of communication messages that are out there. They're broken into bottom line messages, basic messages, which include if you're sick messages that you want to communicate to your employees, return to work, prevention practices at work, and there's a whole variety of messages that are out there. So I really encourage you next week to go to the Toolkit page, and this should be up and running and for everyone to use. The communication plan also contains a list of reputable sources that are out there for information. I know that we are all inundated with massive amounts of information, but this is science-based and it is continuously updated. Okay, now I wanted to cover a few emerging successes and best practices in implementation that we've seen during our field assessments and virtual assistance in beef, swine, and poultry facilities. We've been in a wide variety of states. They're listed here: South Dakota, Colorado, Kansas, Virginia, Delaware, Maryland, Texas, North Carolina, Pennsylvania, Wisconsin, Illinois, and Utah. So we've seen a lot of facilities. And during this time, we have observed best practices and implementation of the CDC OSHA Meat and Poultry guidance. So screening. Now keep in mind that this is not something that you have to do. These are just ideas that we have seen and have worked, they've been operationalized. So employers have hired third-party medical contractors to do screening for staff and visitors. A best practice is to post COVID signs and symptoms outside the plant, in the common languages that are spoken by the employees. And then if you use a thermal imaging system, facilities have said lowering the temperature to 99 degrees helps. And then if there is a higher temperature found in an individual, you can perform secondary screening from there. So this increases the sensitivity of that instrumentation. It's really important to screen everyone, and that includes USDA, food safety inspectors, and package delivery personnel. We don't want to forget anyone. And for the most part, if you can exclude non-essential visitors from premises, you're in a much better place. However, essential services that are listed here, you could permit them into the facility, but you limit their access to the building. That's a best practice. Some facilities have a card that will allow you to enter the facility, and it's recommended that if you can deactivate a card for someone that is ill or has symptoms, is a best practice. Now, screeners are one of the most exposed individuals, and it's suggested they provide them the correct PPE, which is a filter and face piece respirator, face shield, gowns, and gloves, because they may have repeated contact with individuals that they're screening. And it's very important to offer disposable face masks to all the workers before they go into screening rather than later. Sanitation. This is something that is also on the communication side of the house. If you have a document that's posted or a log that shows when areas have been cleaned, this prevents undercleaning and assures workers that the area is ready for use. Another best practice that we've seen is the use of a card system. So when employees go into the cafeteria, there is a card with green on one side, red on the other, and they sit in areas where there is a green card, and then when they are done, they can turn the card to red, and then the sanitation or cleaning staff knows to clean that area so someone else can use it. Physical barriers. We've seen a lot of success in implementing physical barriers along production lines. What we've seen that works the best, though, is to hang these on bars that are parallel to the production line, and then they can be slid to accommodate different heights of workers and different movements and work styles. Always keep in mind that there could be a safety hazard, so it needs to be evaluated. Many of the environments are noisy, and with wearing cloth face coverings, communication is difficult. So as a best practice, we have seen employers have an area where more communication is needed between individuals. They can move to briefly to remove the cloth face coverings or disposable face mask, and they can have communication. But it's important to have this area that either have a physical barrier or is large enough that they can appropriately social distance during their communications. PPE and source control. It's very important to ensure that you adhere to your PPE hazard assessment prior to your COVID PPE. But face shields are considered source control and PPE, and this is something that I think we're going to get to in the Q&A portion of this, and I'll let my OSHA colleague handle this at that time. At one of the plants, we saw an issue with distributing the cloth face coverings or disposable face mask, and this needs to be done in a contactless manner, and it can be done easily by laying these out on the table and letting individuals step forward one by one to get their PPE or source control as needed, and reinforcing the use of cloth face coverings and disposable face masks, in all areas, including parking lots, throughout screening, hallways, locker rooms, and cafeteria, is very important, and we need to evaluate all areas where workers can congregate. And proper wearing of the cloth face covering over the nose and mouth is very important, except when they're eating and drinking. As we all know, staggering shift times, start times, break times as much as feasible to decrease the number of individuals in locker rooms, break areas, and cafeterias is one method to promote social distancing and has worked at many facilities. Another is having touchless clock in, clock out stations and to reduce crowding in these type of areas. And this is something that you really may want to think about, is considering what they call a social distancing champion to reinforce proper social distancing and cloth face covering or disposable face mask use in all areas, parking lots especially, hallways, cafeterias, and remind individuals when they're not properly social distancing and focus on areas where it's harder given the physical space. And we also encourage to empower workers to provide corrective guidance over other workers and reinforce proper social distancing and the use of face coverings. Visual cues on the floor in 6-foot intervals, so individuals know where to stand at building entrances, screening areas, cafeterias, and then in the cafeteria, increasing the distance between the tables. You may have to have another area as an overflow by doing this. You can't have as many workers in the typical cafeteria that you had before. And install barriers at the ends of tables, create a physical divide. Please keep in mind that these need to be at an appropriate height based on different employees and how tall they are. We have seen some of these dividers that were too short to be effective for individuals that were sitting at the table. All right, that concludes my presentation. Here is a slide in which you can ask questions specifically to this webinar. This will be both for Sarah and myself. And the information here, we need you to put your first and last name. You need to identify this webinar by name, and you can send questions to the email address as listed. Thank you for your time today.
Thank you, Jeff. And I appreciate you being so flexible with me and my goof with getting it started for you. I am going to now pass the presenter role to Sarah and let Dr. Lockhart go through and continue. And just so you know, you can continue with the presentation when you get presenter. Perfect, you got it. You are an expert, so I'll let you take it away.
Okay, thank you. And thank you, Jeff, for going first so that you could get the glitches figured out. So I'm Sarah Lockup, and I'm a medical officer with NIOSH who's currently serving on the COVID-19 response. And I was asked to talk a bit about the new information about the testing strategy specific to high-density critical infrastructure workplaces. And I want to talk about that in the context of an overall COVID-19 preparedness and response plan. So I'll start with some background information and the disclaimer. And this is the information that's current as of June 18th, but I did a few updates since then. Overview of my presentation, like I said, I'm going to talk about some background information first on the disease itself, and then talk about considerations for screening for COVID-19 in the workplace, before I get into the specifics of ideas about testing for COVID-19 among workers, and then finish it off with talking about some considerations for managing ill workers. So as you probably know, but I think it's good for us all to remember how this started. Back in December of 2019, a novel coronavirus named SARS-CoV-2 was identified in Wuhan, China, and then the first U.S. case, which was travel-related, was identified January 21st. On January 31st, the Department of Health and Human Services declared a public health emergency. On March 11th, the World Health Organization declared a global pandemic, and on March 13th, President Trump declared a national emergency. And I think we all know what's happened since then. Excuse me. So here's some information on the current situation. As an epidemiologist, I always like to think about the numbers and the maps and the epi curve, which didn't used to be a common term, but now I'm hearing it all the time, the term epi curve. So just to show you where you can get some of these data on the CDC website. The CDC website for coronavirus has lots of different information, but there's one section called Cases in the U.S. that will be updated every day with the total number of cases so far, the total number of state, and what I called the epi curve, the chart in the lower right here that shows the number of new cases each day. And you can see that since the high in early April, cases have gone per day have gone up and down a little bit, but have remained high. So screening for COVID-19 in the workplace. Well, first of all, I have this as a slide to fit into multiple presentations. So I talk about how screening fits into the general business guidance, but this is true for the meat and poultry documents. Talk about how all employers need to consider how best to decrease the spread of COVID-19 and lower the impact in your workplace. And this should include activities that fall into three categories. The major bullets here are prevent and reduce transmission among employees, maintain healthy business operations, and maintain a healthy work environment. And within that first major bullet of prevent and reduce transmission among employees, I've highlighted that consider conducting daily in-person or virtual health checks is just one of the strategies to consider here. So this is just to show that screening for symptoms or doing health checks is should just be part of a wider strategy that includes a lot of different parts. So some considerations if you want to implement screening is that screening employees for fever and other symptoms is an optional strategy. Prior to implementing screening, it's important to ensure that sick leave policies are flexible and consistent with public health guidance, and that employees are aware of and understand these policies, since screening may lead to people needing to take sick leave. And screening cannot be expected to be completely effective in preventing anyone with an infection from coming into the workplace, because asymptomatic individuals or individuals with mild nonspecific symptoms may pass through screening. So another reason for a multi-layered approach to prevention. And screening should not be a replacement for other protective measures such as social distancing. One option is self-screening. I think Jeff mentioned this. So you could consider encouraging individuals planning to enter the workplace to self-screen prior to coming on site and to stay at home if any of the following are present. Symptoms of COVID-19, and I'll talk a little bit more about that in a minute. Fever greater than 100.4 is often used as the threshold. People who are under the evaluation for COVID-19 who have a pending test, and those who have been diagnosed with COVID-19 and not yet cleared to discontinue isolation should also be screened before they try to enter the workplace. So asking about symptoms, I've received a lot of questions about this, about which symptoms to ask about, because you may have noticed on the CDC website that the number of and variety of different symptoms that have been associated with COVID-19 has gotten quite broad now. But that doesn't mean that a screening system should necessarily include all of the symptoms weighted equally. So I think before you start a screening approach, you should consider which symptoms, in addition to fever, to include in your assessment. And so employees with a single nonspecific symptom, such as a headache, that has been shown to be associated with COVID-19 often, might not necessarily warrant a positive screen. So consider focusing the screening questions on new or unexpected symptoms also, because there may be many people with a chronic cough, and that should not necessarily be a positive screen. So one set of symptoms that I think could be considered is to use a set of symptoms that are used for the public health COVID-19 case definition to indicate positive screens from a symptom standpoint. And if you start at the bottom of the list, any one of these symptoms could be considered a positive screen: a new cough, shortness of breath, or difficulty breathing. Whereas the less specific symptoms in the top list, you might want to consider requiring 2 of those before you have a positive screen. Although I do caution that fever by itself should probably be considered a positive screen, since no one with a fever should be let into the workplace in general. But some of the other things like a headache or a sore throat, you might consider needing another symptom. Something you may have heard that's been found to be an interesting symptom of this disease is that many people are having a smell and taste disorder, and that's actually been found to be one of the most specific symptoms for this disease, but it's not always found, so it definitely shouldn't be used alone as a screening criteria, but it might be something to consider in the symptom list. So if you decide to do in-person screening in addition to, or instead of that virtual or self-screening, it's important to remember to perform it in a safe and respectful manner, to maintain social distancing guidelines at all times, to follow guidance from the Equal Employment Opportunity Commission regarding confidentiality of medical records, to prevent stigma and discrimination in the workplace, make employee health screenings as private as possible, and do not make determinations of risk based on race or country of origin, and be sure to maintain confidentiality of each individual's medical status and history. So Jeff talked a bit about the protection of screeners. So the most protective methods, if you're doing in-person screening, are to use social distancing and maintain the distance of at least 6 feet from others. And even if you're having the employees take the temperature on site, you could still ask them to do it themselves to keep the screener from having to get as close to them. The next option is to use physical barriers to eliminate or minimize the screener's exposures due to close contact with a person who has symptoms. And there's a recommended protocol for measuring temperatures this way that's described on the CDC website, especially I know it's in the business FAQ, or frequently asked questions section. There's a lot of information there about screening with a focus on protecting the screeners. If social distance or barrier controls cannot be implemented during screening, then PPE can be used. So testing, how does testing come into play? Well, there are a lot of different tests available now for COVID-19, and CDC first makes a distinction between 2 basic types of tests, which are the viral tests and the antibody tests. So the difference here is that a viral test tells you if you have a current infection, and viral tests have also been called or include molecular tests, RT-PCR tests, nucleic acid tests, and antigen tests. So those all fall under the broad category of viral tests that are diagnostic. And the other big category of tests is antibody tests, which tell whether you have had a previous infection. Now, not everyone needs to be tested for COVID-19. Most people have mild illness and are able to recover at home without medical care. And CDC has provided some guidance for categories of people who should be considered for testing. But the final decisions about testing are made by state and local health departments or healthcare providers. So this is just an illustration, again, to look at the 2 basic types of tests, the viral tests that test for parts of the virus, either the viral RNA, which is the genetic material inside the viral cell, or the viral antigens, which are these proteins on the outside of the cell, or the immune response, which is the antibody tests, also known as serological tests. And this graphic illustrates, the time period for when somebody is infected at day 0 on the bottom. Then they may not develop symptoms for several days, and the period of symptoms is shown in the dark gray-blue area. But the thick lines here show when tests may become positive. So the viral tests may become positive according to the dark blue line a couple days before symptoms start, but are most likely to be positive when there are symptoms. And then in the black and the purple shows when the antibody tests become positive, so they don't become positive until later, and especially the late antibodies or the IgG may not become positive for about 10 days, and they stay positive, so that's why they can't test for that, can't be used to diagnose current infection. So I mentioned that CDC looks at categories of people for testing with viral tests. So the first category is testing individuals with signs or symptoms consistent with COVID-19. I think that's pretty straightforward. But the next two categories are about testing asymptomatic individuals and when you might consider testing them. So category 2 is about testing asymptomatic individuals with recent known or suspected exposure to SARS-CoV-2 to control transmission. And category 3, the third bullet there, is about testing asymptomatic individuals without known or suspected exposure, but for early identification of cases in special settings. And I'll talk a little bit more about both of these categories in the next slides. But just to be complete, the fourth category of testing is when you do testing to determine resolution of infection, which is just one strategy called the test-based strategy for discontinuing transmission-based precautions or returning to work. And the fifth category is testing that's done as a part of public health surveillance. So some information that CDC provides for individuals seeking tests, and it could be useful for employers, is that the availability of testing differs by location. Call your healthcare provider first if you have symptoms, but you can also visit your state or local health department's website to look for the latest local information on testing. And although supplies of tests are increasing, it may still be difficult to find a place to get tested in some areas. The FDA has authorized 2 viral tests that let you collect either a nasal swab or a salival sample at home. However, you'll still need to send your sample to a laboratory for analysis. So the rationale for testing asymptomatic people for COVID-19, I mean, this is a little different than what we recommend for most diseases. And several reasons are that SARS-CoV-2 is very contagious due to a high level of shedding in the upper respiratory tract through coughs and sneezes. Pre-symptomatic people are infectious 1 to 3 days before symptom onset. And asymptomatic transmission is the Achilles heel of COVID-19 control. So this is why that symptom screening, even if everyone is completely honest about their symptoms and the list of symptoms is specific, is not going to catch everybody who's infected. So if you make a decision to implement a testing strategy in the workplace, testing should not supersede existing controls, infection prevention control interventions, other workplace controls. It should be implemented in addition to the other recommendations, and it should be used when results will lead to specific actions. So it's important to plan before you implement testing on what you're going to do with the results. And so now to focus in on that second category of the 5 categories, again, is testing asymptomatic individuals with recent known or suspected exposure. And in the workplace, I think of this as how to end an outbreak, whereas the third category is how to prevent an outbreak from starting. And so in this category of testing those with exposure, we definitely recommend testing for all close contacts who are identified through standard contact tracing as somebody who has spent a large amount of time in close contact with a person who's a case within 6 feet. But in some settings, it can be difficult to identify all of the close contacts, such as in high-density workplaces. And so that's when broader testing beyond those individuals identified by the case may be recommended as a part of a strategy to control transmission. And so we've seen this strategy used in meat processing plants and other high-density critical infrastructure workplaces and in places that have populations at risk for severe disease, such as nursing homes. So you may have seen this. This is some recent information that was posted to the CDC website about a testing strategy for COVID-19 and high-density critical infrastructure workplaces after a COVID-19 case is identified. And I know that the title of that page is a mouthful, but the group that developed the guidance felt that it was important to be specific about when this applies. And some other notes about I just called it guidance myself, but we actually don't consider this official guidance. This is more of a testing strategy that is developed as an optional strategy that augments existing guidance. And it's designed to be an additional tool to reduce transmission and thus protect worker safety rather than new guidance per se. And this is based on the experience of the field deployment teams who saw a need to develop a test-based strategy to assist with making decisions about exposed coworkers. So this takes into consideration the likelihood of exposure, characteristics of the workplace, results of contact investigations, and puts it into a progressive tiered approach to try to figure out how to balance maintaining operations with worker safety. And I know you probably can't read that figure up there, but hopefully some of you have seen that figure already, and if you haven't, I encourage you to take a look at it on the website. It looks a little daunting at first, but if you break it down into the different pieces, hopefully it's helpful for understanding the strategy. So the first part of the figure is about this risk categorization, categorizing the coworkers, and trying to determine whether you want to apply the testing strategy to just the Tier 1 workers, or whether to include Tier 2 and Tier 3 workers. So the Tier 1 are those close contacts of the worker with COVID-19 who are identified by that case through contact tracing. But because in this setting, it's hard to identify everybody that way, you should also consider coworkers who work during the same shift or overlapping shifts in the same area, depending on how the facility is set up. That might be a room or a line or whatever. You should consider them as having more likely exposure in part of Tier 1. Whereas Tier 2 would be a little less likely to have had a significant exposure to the cases. So these could be coworkers on the same shift but in a different area of the facility. And Tier 3 workers are those workers at the facility that are not in Tiers 1 or 2, but may have shared a common space with a worker with confirmed COVID-19. So exposure cannot be definitively ruled out. So if you want to cast a wide net and capture all possible cases that might have been acquired in the workplace, then you might consider expanding testing to Tier 3. But we recommend starting testing with Tier 1 at least. And then the next part of the diagram talks about what to do once you test the Tier 1 workers. So once you test all of the Tier 1 workers, there are 3 different strategies for the timing of the test and the return to work or exclusion from work. So the strategy 1 is to do baseline testing of all the Tier 1 workers who have the most likely chance of exposure, but go ahead and quarantine them for 14 days regardless of the results for the test. And that's really what's recommended in non-critical infrastructure workplaces. They're for exposed contacts to be quarantined for 14 days. Strategy 3, on the other hand, is to do baseline testing and serial testing every 3 days, because baseline testing isn't going to catch everybody who might develop symptoms after an exposure. So that's why we recommend the serial testing every 3 days. But in strategy 3, you can return the workers in a critical infrastructure workplace. If they don't develop symptoms, they can go back to work right away and continue to have the serial testing just to make sure if somebody becomes positive, they're pulled out of the workplace. And then strategy 2 is something in between, to be a little more protective than strategy 3, but not to require everybody to be out for 14 days. It's an option for doing baseline testing, doing the first retest at 3 days, and then after 2 negative tests, allowing asymptomatic exposed workers to return to work. So these are just some strategies for consideration. Tier 2 and 3 workers, on the other hand, who are less likely to have had a really significant exposure to the known cases, we think it's probably more reasonable to return them to the workplace as long as they don't develop symptoms, and consider doing tests or not doing tests. Then what to do to manage an ill worker. So workers who fail entry screening, test positive, or become ill during the day should be sent home, and they should be encouraged to self-isolate and contact a healthcare provider. You should provide information on the facility's return to work policies and procedures, and inform human resources and the worker supervisor so that the worker can be moved off schedule during illness and a replacement can be assigned if needed. Then disinfect the workstations and tools that have been used by the ill worker if they were working while ill. In most cases, you do not need to shut down the facility, but if it has been less than 7 days since the sick employee has been in the facility, then you do need to close off the areas. If possible, wait 24 hours before cleaning and disinfecting. And during this waiting period, it's good to open outside doors and windows to increase air circulation in these areas. If it has been more than 7 days since the person who you find out is sick has used the facility, then additional cleaning and disinfection is not really necessary at that point. Some other things to do if a worker is confirmed to have COVID-19 is to inform all the work contacts of possible exposure while maintaining confidentiality. So let them know that they were possibly exposed at work without naming the person that they were exposed to that has become sick. Provide guidance to fellow workers on how to proceed based on CDC public health recommendations for community-related exposure. Follow appropriate CDC and OSHA guidance for healthcare and emergency response personnel if they're being taken care of by healthcare personnel on site. And it's important to work with the state, local, tribal, and/or territorial health officials to facilitate identification of other exposed and potentially exposed individuals, like co-workers, but also the community and household contacts of the worker. The employer shouldn't be expected to have to identify and trace them. That really is the responsibility of the health department. So then there's information online about return to work after recovery from COVID-19. So we recommend that you look at the information on discontinuation of isolation for persons with COVID-19 not in healthcare settings on the CDC website. And then there's some specific information under the CDC critical infrastructure guidance that talks about the fact that employers may be able to permit workers who have been exposed but do not have symptoms to continue to work in these special industries. But that consultation with an occupational health provider and state and local health officials will help the employers develop the most appropriate plan. And discontinuation of home isolation can be done either on a symptom-based strategy, which has to do with the time without fever and the time since symptoms started, or it can be done by a test-based strategy, which is 2 negative tests 24 hours apart. But we don't feel like the test-based strategy is necessary to be used for return to work, but that is one option. And in some cases, it might allow confidence in letting somebody to return to work before the 10 days. But on the other hand, some people have been shown to have persistent positive tests, so there can be pros and cons to both strategies. And people who have not had any symptoms should wait until 10 days have passed since their first positive test or use the test-based strategy. And here are some links where you can get more information. And as Jeff shared, there's an email address you can use to send questions if you aren't able to get all of your questions answered today during our Q&A session.
Thank you, Sarah. I appreciate all that information. I think that was very helpful. We have some questions building up, but I'm going to turn it over to Dr. Chris Brown to give him an opportunity to share information related to OSHA and the enforcement update. So I'm going to turn that over to you.
Thanks very much. Luckily, I do not have slides to use today, so we will avoid any glitches and hopefully make up a little bit of time on the webinar agenda, and I'll try to keep this brief. OSHA has presented on this webinar series previously talking to your industry, so I think a number of you are already familiar with the resources that we have available, many of which were already mentioned by my co-presenters previously, particularly in that OSHA and CDC are collaborating to provide information for the meat and poultry industries around our comprehensive meat and poultry guidance. We also have a number of other additional supplemental resources that I'll just mention briefly, and those are all available at osha.gov/coronavirus. We've recently posted additional reopening guidance for facilities that have been closed and are looking to reopen or bring back workers, including to physical work sites, and that is available on our website. And that's probably the newest, most relevant thing since the last time we spoke to this group. What I wanted to highlight in the couple of minutes that I have today are some updates about the OSHA enforcement guidance that has also been added to the website probably since the last time this group convened on a webinar like this. Importantly, we've posted updated interim enforcement guidance known as our Interim Enforcement Response Plan, and that details instructions and guidance to our area offices and compliance safety and health officers, or the OSHA inspectors, on how to handle COVID-19 related complaints, referrals, and severe illness reports. And that was issued in May with an effective date of May 26, 2020, archiving our previous April 2020 memorandum on the same topic. So we provided some updated and expanded information that went into effect then. So if you were familiar already with our initial interim enforcement response plan, please make sure that you take a look at the OSHA website and download and look over the new plan, as it does provide additional information about how OSHA is continuing to handle complaints and referrals that our individual area and regional offices receive. We are continuing to go out and do inspections, and a number of meat and poultry processing plants have had those inspections already, so you may have already had the opportunity to interact with our OSHA staff in the field. So we've been out trying to do that work as necessary. During the course of the response, we really are trying to make sure that we are responding in a technical assistance posture. So OSHA is trying to help employers comply with the existing OSHA requirements and make sure that they have the resources and information they need to be able to protect workers. But our ability to enforce and the OSHA standards do remain in effect throughout the course of the pandemic, and that document details what kind of enforcement actions we can and will take, and what tools are available to the agency to respond to the complaints and referrals that we are receiving. As a result of the pandemic, OSHA has also issued a number of additional enforcement guidance documents that detail enforcement discretion that the agency is exercising around a number of our existing OSHA standards. Most of those memoranda that detail the enforcement discretion guidance have to do with OSHA's respiratory protection standards, so they may or may not be as applicable in meat and poultry processing plants, but I want to make sure that you're aware of them and what's there anyway, in case you do have operations that are affected by the limited supplies and other supply challenges around N95 and other filtering face piece respirators, both as a result of the pandemic itself and as a result of the strain on the supply chain because of the healthcare response to the pandemic. So we have provided enforcement discretion around, first, the fit testing requirements for filtering face piece respirators. That's detailed in one memo that extends the initial flexibility we were offering around fit testing in healthcare to other industries. So to the extent your industry is using respirators and experiencing fit testing challenges or strains on your own supply chain because of the burden of fit testing, we talk about information about switching from destructive fit testing methods to non-destructive fit testing methods for respirators, potential strategies for switching workers to other types of equivalently fitting makes and models of respirators based on guidance from manufacturers, as well as additional information about how you can go about conducting fit testing or temporarily suspending annual fit testing requirements for workers who have already received initial fit tests. One of the other guidance documents related to enforcement of the respiratory protection standard covers use of respiratory protection equipment certified under the standards of other countries or jurisdictions. So we are allowing some discretion around use of respiratory protection equipment that you may be able to source from abroad that are certified in accordance with the standards of various other countries that are specifically delineated in that memo. So if you're interested in doing that, and we know that a number of employers have looked at K95s and other types of respirators certainly do make sure that you're familiar with what types of enforcement discretion we're offering around the use of that type of equipment. We've provided some additional flexibility around enforcement discretion for use of other types of filtering face piece respirators as well. And that memo details things like extended use of respirators, reuse of respirators, and use of various other options for sourcing respiratory protection, as well as for making use of stocks of respirators that may be past their manufacturer's recommended shelf life. So if you're planning on doing any of those things because of where you're finding yourself with the respirator supply chain, please make sure that you're familiar with that memo too. Lastly, I wanted to mention that with respect to respirators, that we have issued some guidance around decontamination, and just to make sure that it's clear that that guidance applies only in healthcare and not to other industries. So that one's going to be of less interest to you, but just highlighting that here, that it only applies to healthcare to avoid confusion, because we have received a number of questions about the applicability of that enforcement discretion. We've also received a number of questions from employers about OSHA's existing recording and reporting occupational injuries and illness requirements, or the 29 CFR 1904 requirements. A number of the questions that were submitted ahead of the webinar today get into those types of issues. So I want to make sure that everyone on the webinar is aware that we are providing enforcement guidance around those issues too. We had initially issued some enforcement guidance that was in effect until May 25th, and then as of May 26th, we're providing revised enforcement guidance for recording cases of coronavirus disease 2019, or COVID-19, the subject of today's webinar. That guidance memo talks about OSHA's record-keeping requirements and how employers can go about making work-relatedness determinations, and lays out the general requirements for recording cases of COVID-19 when a case is a confirmed case of COVID-19 is defined by CDC, the case is work-related is defined by 29 CFR 1904.5, and the case involves one or more of the general reporting criteria set forth in 29 CFR 1904.7. That enforcement guidance also provides some additional information to help employers because of the difficulty that OSHA recognizes with determining work-relatedness during the pandemic. And we provide some examples that can help employers in determining what their obligations are for making a reasonable determination of work-relatedness. It lays out some examples of evidence that employers might consider, how they should go about asking workers about potential exposures, and how they can go about weighing the balance of the evidence that they discover in the course of their investigation. So if you're not familiar with that, I do encourage you to check it out, because our expectation right now is that it's much closer to what the existing requirements were before the pandemic. We had initially, during the early phases of the pandemic, offered some additional flexibilities, but as things have begun to stabilize and employers have gotten more in the swing of implementing the types of infection prevention measures that OSHA and CDC are recommending, our hope is that we could move back towards closer to the regular recording and reporting requirements that are in the existing requirements. So I'm sure we'll address that topic a little bit more in the question and answer portion of today's webinar. But again, please do check out all of these memoranda that detail the enforcement discretion that I've mentioned today, and those again are available at osha.gov/coronavirus. So that concludes my portion, and I will turn it back over to our host.
Thank you, Dr. Brown. I am now going to turn it over to Paul to discuss how OSHA consultation is available for companies throughout the country. I want to give a shout out. I've already heard that there is a couple other programs throughout the country on the call, like Delaware and Maryland. So we've got lots of people. So I'm going to turn it over to Paul and let him present.
Thank you, Jenny. Can you hear me okay?
Yes, we can.
Great. And you're now looking at the consultation, the first consultation slide, correct?
Yep.
Okay, great. Well, once again, thank you, Jenny, and thank you, everybody. I want to thank our distinguished panelists, some really, really valuable information, and thank all of you for joining us. I know several of my colleagues are on this call. I also noticed South Carolina, the consultation program in South Carolina. So
And Wisconsin.
And Wisconsin. Thank you, Jenny. I'm walking into this with the assumption.
And Florida and Alabama. So let's just say everyone's on the call.
Florida and Alabama. Welcome all of you. We appreciate you joining us. You know, Consultation's been around for quite some time, so I'm assuming that a lot of you are at least somewhat familiar with Consultation or have heard of it. But you know, you've received so much good information in this webinar about resources that are available to you. We didn't want to leave without telling you more about Consultation and how we can help you both with COVID-19 assistance and just in general with occupational safety and health assistance. So the slide you're looking at is just a general overview of the on-site safety and health consultation program. Of course, my name is Paul Schlumper. I work in Georgia, so I represent the consultation program in Georgia. But a lot of the things that I'm going to talk about are very transferable to the other states and my other colleagues. So the consultation program, as some of you are aware, is available at no cost, and it is completely confidential. We don't share any information outside of, in Georgia Tech and the client company that asks us to come in. So we're there to try to help you. We've been around, I think we're in our 42nd year now of providing consultation in the state of Georgia. And again, a lot of my colleagues I know have been doing it at least as long. So the program is available, you see, to small and medium-sized businesses. The cutoff that typically is offered there is 250 employees at the facility or establishment and 500 employees total U.S. corporate. Now, having said that, you know, yes, we are instructed to focus on small to medium businesses, and that hasn't changed. But if you look down on the slide, we have been encouraged to at least use some of the allowance that we have to work with larger businesses in working with the poultry and meat processing industry in response to COVID-19. So while we still are focusing on small to medium businesses, we are able to work with you, especially on COVID-19 type issues, if you're larger than those numbers that I just presented. So please consider Georgia Tech in the state of Georgia and all of the consultation programs to be a very valuable resource at this time. Now, the second bullet does describe the fact that consultation is separate from enforcement. So we don't issue penalties, we don't issue citations. As many of you are aware, there is a requirement for anyone who receives a consultation visit to agree to correct any serious hazards that are identified as part of the consultation process. So please understand that there be some resulting action that you would have to take as a result of the visit, but it is completely separate from enforcement activity. So one thing about the state of Georgia, and I know it's true of some other states as well, is that since around the middle of March, our assistance, the on-site portion of the on-site consultation program has kind of been put on hold. We have been doing a tremendous amount of work with client companies on a remote basis. So, and believe me, there's a lot we can do remotely via formats like this, like WebEx or BlueJeans or Zoom or other types of formats. So even though right now we're still working on our transition plan to getting back out on site and getting back into your facilities and onto your job sites, there's a lot we can do right now to help you from a remote basis. So Jenny, if you don't mind putting in the chat our web address, or if you haven't done so already, in the state of Georgia, our web address is oshainfo.gatech.edu. That's where you would go to request an on-site or remote visit from our consultation services. And then the very next slide, are you looking at the slide with the directory now?
Yes, we are.
Thank you, Jenny. For those of you that are outside of Georgia, it's very, very easy for you to find the consultation program in your state. You can go to OSHA.gov, go to the cooperative programs page and resources and on-site consultation. The direct web link is shown on this slide, the consultation directory, and basically you just go to the directory and pick your state out of the United States, and you can get the contact information for requesting either an on-site or remote consultation assistance for your facility in that state. So the message is very clear, and I wanted to be brief to allow for question and answers from the panelists, but we're here and we're very eager to help you, not only with COVID-19 and you're getting back to work and the safety and health of your employees in that respect, but just in general, occupational safety and health. We are a resource. We hope you'll take advantage of it. So with that, Jenny, I'll turn it right back over to you. Thank you very much, everybody.
Thank you very much, Paul. And so now we are at the question and answer period. So I'm going to start with one of our first questions. And if you want, I've got a couple already queued up, but if you have questions, feel free to type them in the chat window. They come directly to me, so I will be able to filter them out and present them to all of the panelists. So the first question is really more of a discussion if there's anything you need to keep in mind when it comes to accuracy for temperature readings, and mentioning that truly accurate infrared temperatures are taken from the eyeball. So does anyone want to comment on making sure you're getting accurate temperature readings and what's the best practice for doing that?
I'm sorry, I think that might have been a good one for me. Could you please repeat the question?
Yes, Sarah. There was a comment about getting more accurate temperatures using infrared thermometers, and if there's any recommendations as far as accuracy for temperature readings.
Oh, well, actually, with the infrared temperature scanners, I think Jeff touched on the fact that it might be that you want to set the threshold low to make sure that you're as sensitive as possible and capture anyone who might have a fever. So you could flag anyone who has a temperature of, say, 99 degrees through that way and do a repeat temperature check on them with another more accurate method.
I think that's a great one. You know, last time we had a call, they had mentioned one of the companies that shared their success story was doing a screening similar to that. The next question is, it kind of relates to what you mentioned, Sarah, where you're saying every 3 days for doing testing and some of the different testing strategies. But they wanted to know, like, if you're not doing testing on a regular basis, how often should you periodically go back and screen workers? So should it be once a month, once a week? What would that screening look like?
I'm just trying to think. So the testing strategy is based on the idea that you've already identified cases within the workplace. So basically the testing after that depends on when and how many cases you've identified. So if you're identifying cases through symptom screening or through workers going to see their clinicians on their own, and then you find out that there were cases, that's when you should start thinking about applying the strategy again, and whether it can be narrowed down to a small group of the closest contacts and that group tested, or whether it appears that there may have been a lot of contacts that may have been exposed and they might need to be tested. And then we recommend doing at least the baseline and then 3 days later for those who haven't developed the positive test right when they get infected.
Great. So you did mention that there is proof of asymptomatic, or there is evidence that there is asymptomatic COVID-19 transmission. Does the CDC or can you point to any actual studies that have been conducted that employers who need to kind of give evidence of that type of transmission to upper management, or they can share that resource?
Oh, that's a good question. I believe there are some references for that on the CDC website, but I can look for the specific references and follow up with you on that if there might be something more specific needed.
That would be, I think, would be really helpful, and I can send a blinded email to the participants of this with those links at the end of this session. One more question for you, Sarah, and then I'm going to switch to OSHA for some questions for now. Do we know for the current testing protocols what the accuracy and specificity are of the COVID tests? Like, what are the number of false positives and false negatives related to COVID-19 testing?
That's a difficult question because there are so many different tests that are being used. So it really depends on the specific test that's being used. And also sometimes it depends on how well the test is being performed. And also the underlying prevalence or how common infection is in the population can change the positive predictive value and negative predictive value of a test. So it's good to work in consultation with an occupational health provider or with the state or local health department in selecting a test and determining what the chances are of having false positives and false negatives with that particular test are.
Thank you. So this question might be for Dr. Chris Brown or anyone else with OSHA, but we did have some participants bring up the recent directive that was passed in Virginia, and they were curious if you could comment on the first pandemic workplace safety mandates being passed in Virginia and how that will reflect within OSHA.
Sure. I can't, really get into the specifics of any potential actions that OSHA might take, but I can tell you that we're, of course, closely monitoring what Virginia is doing with respect to their requirements for COVID-19, since Virginia is an OSHA state plan, and we do, regular monitoring of all of our OSHA state plan programs to make sure that they are providing requirements that are at least as effective as those of federal OSHA. Certainly, implementing these types of requirements is one way that OSHA state plans can go about making sure that workers in their state are protected. Federal OSHA is continuing to monitor the evolving pandemic and evaluating the ways that we can best support employers and workers, including in returning to work as the pandemic evolves. And of course, we have a variety of tools available to us at the federal level that includes not just things like our existing OSHA standards, but also the various types of guidance we're providing from OSHA and with OSHA and our interagency partners together.
Thank you, Chris. Does anyone else want to comment on that? Should I move to the next question? I will take that as a moving on. So this one I think is going to be for Jeff. And I often get this question when we do consultation with companies. So I think this is a great question because it gets really tricky. So the question is, when looking for close contacts, how do you incorporate whether or not you need to include somebody or say that somebody's a close contact when you are looking at things like if they were wearing masks, if they were both wearing masks, if they're working and they've been separated by partitions or other precautions that are in place? Like, how close is close enough to consider them a contact when you are looking to do testing and expand the testing related to the engineering controls?
Thank you. I'd be happy to try that, and maybe Sarah can add that to this answer also. But you need to take a risk-based approach, obviously. And all those control methods that you mentioned, as source control and cloth face covering, or an engineering control with a partition, that would minimize the potential for exposure to the virus. However, the only in the main control is social distancing with a 6-foot. So barriers do not replace social distancing, and cloth face coverings do not replace social distancing. So if you have an individual that was in close proximity, which means 6 feet or more, and a time range of at least 15 minutes, they should be considered for follow-up. That's based on what I've read and my knowledge of this. Sarah, do you have anything to add to that?
Yeah, I agree with what Jeff has said, that really the definition of close contact is based on that 6 feet distance and the 15 minutes or more in close contact. But a lot of different engineering controls and administrative controls can reduce the amount of time that people are within that that proximity to each other. And so those should be taken into account when determining how likely it was that people were exposed that closely. Cloth face coverings don't really change how likely you are to be within 6 feet of each other. So those are considered as an additional layer of protection, but don't necessarily factor into who has been a close contact. And it's also important to note that just having engineering controls and administrative controls in place or a box checked, it's important to go beyond that and make sure that they are designed and implemented and that adherence is as high as possible, and make sure that they're done very thoughtfully.
Thank you. That explanation was very helpful. The next question that we have is, how can we keep workers separated on the processing line when they stand elbow to elbow normally? So I guess this question is more possibly could come even from any of the representatives from the poultry or turkey associations as well, for recommendations on how you get that separation even when the work needs to be done in close proximity to keep up line speed. Anyone want to take a stab at it?
This is Jeff with CDC NIOSH. We have diagrams within our code writing guidance that has the work alignment that would be ideal. So social distancing is the primary mitigation strategy. Now, I realize that the workplace may be designed that employees are in close proximity, but that's something we want to follow a hierarchy of controls and try to mitigate. If you cannot have social distancing, the next best thing is a physical barrier, which in the poultry industry has been implemented widely. We want to make sure that they are effective and utilized as they should be, but the primary would be social distancing when possible, and production changes may be required for that, and aligning of workstations. We are in this for the long haul, unfortunately, and we need to remain vigilant and ever improve and follow the hierarchy of controls to mitigate this. So in those situations, physical barriers are commonly what we see. Thank you.
Thanks, Jeff. So this is a question that we get often from all different companies, and Sarah mentioned it a couple times, and Dr. Brown and Chris mentioned it as well, that PPE is listed separately as cloth coverings. So I was wondering if one of you would mind giving a brief explanation as to why cloth coverings are not included in listings as typical or classically understood personal protective equipment.
Well, this is Chris Brown from OSHA. I can take a first stab at that one. I'm happy to have any additional input that my co-presenters on the phone want to offer. So first, folks who are interested in this, I really encourage you to check out the frequently asked question items that are on the OSHA.gov/coronavirus page. We added some cloth face covering FAQ items a couple of weeks ago that delve into the differences between cloth face coverings, surgical masks, and N95 or better respirators that really highlight some of the key points that distinguish those types of equipment from each other. Basically, getting right at what you're asking with respect to this question, PPE like respirators or surgical masks are intended to, and to some degree or another, regulated to and tested against certain standards and requirements in order to be able to provide protection from various hazards to the wearer. When we're talking about droplet hazards, for instance, like splashes or sprays of liquids or body fluids or other droplets in healthcare and other settings where those have been increasingly used over the course of the pandemic, surgical masks can provide protection against those types of liquid exposures to a wearer's nose and mouth, and when coupled with eye protection like goggles or a face shield, to the eyes as well. Respirators, as most of you probably know, provide protection from airborne contaminants to the wearer because they provide a seal to the face and can filter out those materials depending on what the particular respirator and the cartridges used with it, if applicable, are rated for. When we're talking about cloth face coverings, those are intended to protect not so much the wearer, but other people around the wearer from the wearer's potentially infectious respiratory droplets. So cloth face coverings are intended to contain those respiratory droplets so that you're not spreading the coronavirus to other people who are around you. Their intent is not to protect the wearer, so that's why we do not consider them personal protective equipment. They also aren't, like I said previously, tested against any of the consensus standards or other requirements that OSHA, FDA, or other agencies have for those types of equipment, and can vary widely in their construction just because there are so many different options for commercially available ones that are manufactured intentionally as cloth face coverings, and then other types of cloth face coverings that can be improvised from things like bandanas or scarves or made out of t-shirts or old socks or anything like that. And we've seen a number of different types of those cloth face coverings being worn in order to implement what is CDC's public health measure versus the types of protective equipment that are used for hazards in workplaces. So that's really what distinguishes them, at least from OSHA's view. I certainly welcome any additional input from CDC if you have other thoughts.
Thanks, Chris. That is exactly correct. Cloth face coverings are not PPE. They do not have an assigned protection factor, and Chris stated that masterfully, so thank you.
Thank you very much. And I am about to add the links that were just shared to all the participants. So the first one is a FAQ related to face masks, and then the other one is the general FAQ link for the CDC, so you can find answers to some of your burning questions related to COVID that you may be able to find the answers on their website. Okay, let me see what the next question will be. So the next question is comes related to a company that has a large local medical facility, and they began using a test-based strategy earlier this month. And so they have been doing a lot of testing, and they want to know if it's allowed for them to have their employees return to work based on the symptom-based strategy in lieu of waiting for their primary care provider to release them. I think that might be for Sarah.
Yes, we think that the symptom-based strategy is one option that should be used for allowing them to return to work, because we know not everybody has equal access to being able to see a primary care provider to release them, especially during this time when some of the healthcare providers may be overwhelmed. So again, that symptom-based strategy is that they should have no fever for 72 hours without fever-reducing medicine, improvement in respiratory symptoms, and at least 10 days have passed since symptoms first appeared. Or if they didn't have symptoms and just had a positive test, then it should be at least 10 days have passed since the first positive test.
Great, thank you, Sarah. We do have a question, and this is for both OSHA and NIOSH. Are you aware of any research that's being conducted on the effectiveness of physical barriers in the poultry operations with regards to the orientation of the airflow? So when we put up these physical barriers between individuals who are working closer than 6 feet apart, is there research being conducted that you're aware of to determine the effectiveness?
This is Jeff, and I'm not aware of any research, but physical barriers are a long-standing controlled method that can be utilized, and at this point, they are being implemented widespread and appear to be effective. But as far as research goes, I am not aware of it.
And this is Chris from OSHA. I'm not aware of any particular research in this area either, but would just add on to their, what Jeff was saying about barriers being a long-standing control measure. We do have a fairly good understanding about how large-size particles, including respiratory particles, behave, and our recommendations are based on what existing science was already available when we began developing these recommendations for the meat and poultry industry. So, if it's encouraging to folks, these were not just sort of pulled out of nowhere. This was really based on what we understand about how droplets spread from person to person and the effectiveness of barriers in arresting that spread. We do encourage in the guidance for folks who have concerns about airflow within a particular environment to consult with ventilation engineers, because they really are in a position of expertise to help determine whether positioning of fans and vents and other elements of a ventilation system are otherwise impacted in control measures and the effectiveness of those intended control measures that have been installed in a work environment.
Thank you. So before I get into the next question, I do have a wonderful offer from OSHA that there are individuals on the line to answer any record-keeping questions related to COVID. And we have only had that one question come in so far, so please message me your record-keeping questions because I know that they're out there so we can address them. So the next one is a request to clarify that if you're less than 6 feet apart for more than 15 minutes with cloth face coverings, interactions, that should be considered as close contact encounter when doing a contact traceability, even though a face covering was used by all parties. So this is a clarification. You're less than 6 feet apart for more than 15 minutes of time, but both parties were wearing face masks.
Yes, as of the information, the scientific evidence that we have right now, we're still considering that to be a close contact because we don't have enough evidence to be confident that that is protective enough to not be considered a close contact.
Thank you, Sarah. I think it's helpful to think about cloth masks, if I may interject, as risk reducers, but not eliminators, whereas respirators really help to eliminate that risk. So even if you're within 6 feet, you're reducing that risk of exposure, but you're not eliminating it, which is why you have to keep that in mind.
Yeah, I think that's a good way to look at it.
So right now, I don't have any other questions coming in the queue, and I think I've gotten to all the ones that have come through. So I do want to leave you guys for a last minute to jump in and say anything else you want to mention. Otherwise, I think we've answered all of the questions that have come in. So Jeff, would you like to say anything else about any of the discussion?
Closing comment from me, there was a question about basically capacity for a room, and there is no guidelines or capacity of a room. It's all based on social distancing. There has been particular attention placed on very small rooms as part of the audits we've done. If you have a room that is 10 by 10 and it may be used for a specific purpose, that is an area that you may want to analyze very closely and limit, because it's not possible to social distance in that area unless you install some sort of barrier or another control method. So I would really encourage everyone to be relentless in your pursuit to find hazards and COVID-type hazards, and really look at places other than production, because you can have exposure to COVID in areas that you may not realize. So check and check again, because you may find something that you didn't see last time you did that. And I appreciate everyone's time. Thank you.
I think my last call for questions brought in a few extra questions to be answered, so I'm going to circle back to them. The first one is there any research being done on the saturation of face masks or respirators on their effectiveness, being that the poultry industry is fairly wet in an environment, and that they may also very hot, so there may be a combination of moisture from the air and also perspiration from the employee. Are you guys aware of any research in that area?
Well, I can start off, and if Jeff wants to add anything, that's fine. This is Chris Brown from OSHA again. I'm not aware, again, of any particular research in this area. The guidance that OSHA and CDC and NIOSH are providing around face coverings already talks a bit about some concerns with this and considerations for cloth face coverings becoming wet, particularly in very wet work environments like meat and poultry processing facilities. And we've provided some recommendations for employers to consider ways for periodically changing out those cloth face coverings or using alternatives to the typical cloth face coverings that may provide some better resistance to and protection against the kinds of droplets and from just the wet working environment, as well as some of the preservation chemicals that are involved in these types of operations. We also have heard from some stakeholders that we haven't explicitly recommended it because of our continued efforts to try to prioritize respirators for the healthcare industry, that some stakeholders were considering using various types of respirators that, you know, are well known to be able to stand up to these types of wet environments. And I believe on one of the previous webinars that some of you may have been on, because it was with a number of stakeholders in this industry, some industry folks mentioned that they were looking at potentially using things like powered air purifying respirators because they provided both face and eye protection that were useful for shielding workers from the wet environment, from potentially infectious respiratory droplets from one another, and could stand up to the types of moisture considerations that are in these types of working environments.
Thank you, Chris. And if everyone has time, I've got two more questions to go. The first is more of a record-keeping question, and the question is, do temperature screening records need to be retained per the Access to Medical Records standard?
So I will give you the quick answer on that, and then I have Elizabeth Grossman and Valerie Scrooby from OSHA's Office of Statistical Analysis that deals with our record-keeping requirements. They're both on the line, so if they want to add anything on, please feel free. We have provided some guidance around this already to employers, and the requirement under that standard is that if you make a record that qualifies as a medical record, that it needs to be retained for the duration of employment plus 30 years. And we've provided on the OSHA website some additional detail about what constitutes a medical record, including when and how and by whom the medical record would need to be made in order to qualify as a record under the standard. We've generally suggested that employers, you know, take those kinds of considerations into account to determine if it's necessary for them to make a record. And in some cases, they may be able to implement a temperature screening program where, for example, they're doing real-time screening and either allowing in or excluding particular workers based on the results of that temperature screening without a need to document each worker's temperature upon entry into the facility. But again, that's up to the individual employer to decide if that's what they want to do and how they'd like to implement that type of screening. Liz or Valerie, do you have anything else that you wanted to add on to that?
I don't have anything to add to that.
Okay.
Thank you. And so the last question we have today is that, once again, I think this goes to Sarah, and Sarah can give her parting comments as well. But to clarify that with physical barriers and cloth face cloth face coverings and a face shield would not compensate for social distancing when it comes to contact tracing. So they just want to hear that one more time, that it's the 6 feet apart for contact tracing as far as positive cases, but the physical barriers and cloth face coverings and face shields do not supplement for that.
Yeah, that is our current recommendation, that unless that the control actually keeps people 6 feet apart, which maybe in some cases barriers can, that they should still be considered close contacts for contact tracing purposes. And so, yeah, I guess my closing remarks would just be to emphasize the need to implement several layers of protection, because any of these things on their own, screening for symptoms, doing tests, having barriers, using cloth face coverings, may not be 100% protective, but the more things you can put into place and the more thoughtful the prevention and control program can be, the better chance it is that you will be able to prevent or limit transmission.
Thank you, Sarah. Chris, did you want to have any closing comments?
No, just thank you very much for allowing us to be on the webinar. We always appreciate these opportunities to do outreach to the stakeholders, and thanks to the OSHA staff who made sure that this was put together, and to all of you for executing. If there are any further questions for OSHA, please don't hesitate to get in contact with us. The contact information for all of the individual OSHA regional and area offices is available on the website, and we also have an e-correspondence form through which interested people may submit questions, and our subject matter experts can answer those questions and get back to you. So if there's something we couldn't cover on the call today, feel free to utilize that or follow questions through your point of contact for the webinar. So thanks a lot.
Thank you, Chris. And I'm going to turn it over to Matt so he can close the presentation.
Thank you, Jenny. I want to thank everybody again from OSHA and CDC for participating and answering the industry questions today and going over a lot of great detail. I want to thank our partners with NCC and NTF as well for all the questions our members brought in, and hopefully got answered again. If you have any questions and stuff, please make sure we'll reach out to OSHA and the resources and stuff available, made available during this webinar. And again, big thanks go to Georgia Tech for hosting and moderating today's webinar, and appreciate everyone's time today on this important topic.
Thank you for attending this session. Everyone have a great day.